Bom, dando continuidade, né, teremos agora a segunda palestra, ministrada pelo professor doutor Alexander Valent, graduado pela Universidade de Paris, PhD em Cytogenética na National Cancer Institute, Bratislava, Eslováquia, e é especialista em citogenética molecular no Institut Gustave Roussy, Villejuif, França. A palestra é intitulada Frequent Epithelial Cancer, Lung, Breast and Prostate Cancers. Thank you.
Thank you. So let's talk about some epithelial cancers after this history of cytogenetic. If you have any questions, you can ask me right away in the middle. If it's not clear or you have an experience and you wanted to add something, you can interrupt. There is no problem. So please do not hesitate to ask the question. So just a brief summary, the slides I showed this morning, that we have all these different genetic methods to do genetic exam in cancer cells. And in our lab, we use mainly cytogenetic methods, which means karyotype for leukemias and lymphomas, hybridization in situ, and CGH arrays. And then in a molecular biology lab, which is next to our lab, they use quantitative PCR and sequencing. So I'll be talking a lot about fish because the main part of my work is doing fish exam. So let's start with non-small cell lung cancer and some examples, and I'll speak a little bit in details about ALK gene. Then we'll go through breast, and in the end, a couple of slides about prostate cancer. So there is a proposed histological classification on non-small cell lung cancers, which was published first in 2004. But there are new proposals published 2012 to reclassify some tumors. Some of you are familiar with histology, and I listed here the most frequent types of adenocarcinoma. It can be a lipidic type, or acinar papillary, micropapillary, or solid with mucin. Why it's important for molecular pathology to do this connection between pathology and molecular part. It is very important because when pathologists make an exam and see the histological type, he can have already very precise idea what is going on in genetics. So, which is on the next slides. As you can see, the histological type can be very closely associated with some type of mutations. There are several mutations like EGFR gene or P53. They are not exclusive mutation, but for example in lipidic adenocarcinoma, EGFR mutation in never smokers is up to 30%, and in some cases in up to 50% in amplification. So altogether, EGFR and lipidic subtypes can go to up 80%. So if pathologist sees something, he can go and ask very specific exam in molecular biology lab because he knows already which is typical for that tumor. And for example, there is invasive mucinous adenocarcinoma, and KRAS mutation is detected in 80 to 100% of cells, and there is no EGFR mutation. So pathology and genetics is really close. And as you saw, example of Ewing sarcoma, one gene can be implicated in several pathologies. So this is good to know that we have a link between the histological type and genetics. The other slide is the similar, and this is by region. The previous slide was by gene, histological type, and gene, and this is the similar, except of I put the gene region and what is the problem. So genetic aberration can be either amplification or deletion. There is a subtypes, and there are oncogenes which are located in this region. I give here the paper which is giving this detail, so then I can give you a PDF file. You can find the very nice paper talking about genetic alterations, which kind of genetic alteration and which subtypes. So what we detect frequently is ALK gene, but this gene is not the only gene which is detected in non-small cell lung carcinomas. What can be genetic aberrations? Genetic aberrations are either mutation, either copy number changes, structural rearrangement, or epigenetic aberrations. So for mutations, there are many genes, they are sequenced, not all genes, but some part of genes, hotspots in the genes, and hot mutations are known for EGFR, KRAS, BRAF, HER2, TP53, AKT1, TDR2, protein kinase, PTEN, FGFR1. Then you have a copy number change. It means gains or amplifications. It concerns oncogenes, or deletions, and this concerns tumor suppressor genes. If the tumor suppressor is lost, there is no control of the cells of proliferation, so the cell can go and start this proliferation process. Or on the other hand, if there is an amplification of some of proto-oncogene, like EGFR, FGFR1, MET, and others, again, the cells will accumulate the protein corresponding to these genes, which will start the cell division process, and the cell will go from G0 phase to mitosis, to cell cycle. Very often, what I mentioned this morning, very frequent, very often we find the translocations in NSCLC. There are translocation and inversions of very often ALK. If it's not ALK, it can be ROS1. If it's not ROS1, it can be RET or other genes. And in the end, very important, there are some epigenetic aberrations. It means that the genes are intact, but there are some gene modifications, like methylations of the gene, and methylation will change the expression pattern. So there is no mutation, gene itself is intact, but methylation gene makes the gene will become silent. Or demethylation make the gene will be expressed, and it shouldn't be. So what is interesting in this table is that one gene can be modified by different mechanisms. Like, for example, FGFR1 can be either mutated, either we can find structural rearrangements, or it can be as well amplified. So one gene can go through different mutation, but the results in the end will be still the same. It will restart the cancer process, and the cell will turn to a cancerous cell. What is this famous ALK gene? ALK came from anaplastic lymphoma kinase, was first identified in 60% of large cell anaplastic lymphomas. And later on, this gene was identified as translocated in 3 to 4% of non-small cell lung cancers. The gene is located on chromosome 2, on the short arm on chromosome 2, and its function is in a central nervous system development. So it's a very important function, and this function, the gene is normally expressed in utero. In adult tissue, the ALK gene is not expressed. So that's why if there is expression of the gene due to translocation, the expression of is cytoplasmic. So if you see by immunohistochemistry ALK gene expression, it's clear that the gene is rearranged and it's closely related to the cancer and adenocarcinoma. This gene is activated by inversion and creation of a new chimeric gene which activate the tyrosine kinase part of ALK gene. I'll show you on next slide what does it mean. So the ALK is tyrosine kinase receptor, which is on a membrane of the cell. And when we have a translocation or inversion, the gene is broken here, and this part will be replaced by another gene and will activate this domain. So what happens next? This domain will send to the nuclei constant signal to go to cell division, but there is no ligand here. It was just the chimeric changes, the new gene which is created, which has a new function and which cells to signal to divide to the nucleus, to the cell to start its cell division, but it's artificial signal because of which is a result of the translocation. On a molecular level, the translocation is on the same part of chromosome and it's inverse in inversion. This phenomenon, it means the two chromosome bands are inverted. So there is gene ALK, and in normal cells there is close to this gene in opposite strand is gene EML4. What happens where there is an inversion, this EML4 will connect to ALK and the fusion protein will change, will deregulate cell cycle, cell proliferation, angiogenesis, and cell survival. So this is very important when the processes of carcinogenesis starts. What are translocation partners? As we saw on previous slides on this one, the most often partner is ALK gene is EML4 gene. What is interesting on this? The breakpoint in ALK is the same breakpoint. It's in exon 20 ALK. The breakpoint on partner gene EML4 is a different part. You see that it can be different. It can be exon 20 or 18, 14. It depends. And plus, ALK can have a different partners, but the result still is activation of ALK gene. So why we do exam of this gene? Because there is a targeted therapy. The targeted therapy is a small molecule called crizotinib, which you will see on next slide. And what does it do? As we saw, the new fusion gene ALK and EML4 creates a new fusion protein which will promote the survival and which will promote the cell proliferation. So if you apply this really tiny small molecule, it will block the protein and it will restart apoptosis. But what can happen, especially in relapses, then there is a mutation of a fusion gene, and this mutation make that the molecule, which was specific and very efficient before, doesn't work. So that's why targeted therapy works in the first instances, but sometimes in relapses, targeted therapy doesn't work anymore because there are additional genetic changes. So that's why the relapsed patient doesn't answer to the molecule they used to answer before. Or another possibility, there is no mutation, but another signaling way takes away and takes over this way. It can replace the fusion protein function and can promote the survival and cell proliferation. So how it works, this molecule? It's really small molecule. You see, it's not very complicated, like when on 10 different lines to write the chemical structure of crizotinib. this molecule, this is a chimeric protein ALK-AMLK4, and this small molecule will go to bind to this pocket. So it might bind to this ATP site, and it will prevent phosphorylation, which is a key factor of the activation of chimeric protein. So it's quite simple concept, but it was hard to find it. It was years and years to find out how it works. So what is very important, as I told, with evolution of a tumor, we can have, in a beginning pre-treatment, we can have some kind of molecular profile, which will change after the first chemotherapy, but chemotherapy itself can induce the genetic changes, especially the one which attacks DNA. And tumor cells themselves, they make an evolution, and they can do and acquire a new mutation. So it is very important to think of it, because when we have a relapse, the same therapy is not convenient, or the patient is not responding to the same therapy, and it's obvious why. You see that the spectrum, which is quite complicated, and I'm not going to the details, from pre-treatment, first treatment, and the second relapse is not at all the same. So how it looks like in microscope, this is more interesting part. We have a gene, and the gene is detected by, what does it mean, the split probe? I explained it yesterday in a pathology meeting. Split probe is a probe which is designed to cover the gene, which is composed in 2 different colors. And if the gene is normal, the 2 colors are touching each other, are overlapping, it gives a yellow signal, or green and red signal very close to each other. When there is a translocation, this probe will split here, and we will have some green and red signal separate. Or if there is an additional genetic change, like in this tumor, after the translocation, there is a deletion of this part of the gene, and we found in the cells only red part, but it still means positivity. So either red and green, or red itself are positive tumors and will be a response to crizotinib therapy. What are other genes which are rearranged in non-small cell lung cancers? The first one, which was described really a long time ago, and the one of the first specific targeted therapy was directed against is EGFR. It's epidermal growth factor receptor, which is on chromosome 7, which promotes proliferation and migration cells. And here I put the 2 molecules which are used really for a long time for patients with this lung cancer, but in other pathologies. Other gene which is very important is DDR2, which promotes adhesion, proliferation, and migration of cancer cells. This gene is located on chromosome 1. Other one is FGFR1, which I'll talk about it in breast cancer, because it's expressed in lung cancer and amplified in breast cancer. Very important, the genes which are responsible to relapse and no answer to the chemotherapy are a family of ERCC genes. It's excision repair cross-complementing gene. Why it is important? Because classical chemotherapy will attack the cancer cells and especially DNA. And if the DNA is blocked, the cell will stop divide. The problem, if these genes are overexpressed or amplified, the damages which are caused by classical chemotherapy are repaired much more quicker and much more efficiently than in normal cells. So that's why a lot of patients are resistant to classical chemotherapy or can acquire resistance by making mutations or amplification in genes which are responsible for DNA repairing. And the last gene we do exam in our lab is MET gene, which is in chromosome 7, and which again proliferates migration, invasion, metastasis, and neoangiogenesis. There is a lot of other genes like platelet-derived growth factor alpha, KRAS, HER2 gene, which is amplified in breast cancer, and I'll talk about it really in details in 10 minutes. But there are many mutations of HER2 genes. Then there is a ROS1, RET, VEGFR, and other genes which can be mutated or amplified in lung cancer. What is very important, we can have a cancers there, they have few abnormalities, or there are no abnormalities on genetic level, there is no mutation, deletion, or amplification, but these genes can be inactivated or activated by methylation. So if the gene is methylated, the transcriptional activity is stopped. It is demethylated, it starts the transcriptional activity, and very often in cancers there is a methylation problems. So now we go to the breast pathology. We can look it up from two different angles. Since I do genetics, because it's all I know, there are two different kinds of breast cancer. Breast cancer can be inherited breast cancer and sporadic or somatic breast cancer. I will have a long talk about somatic mutations, but I wanted you to know that there are very important genetic factors, BRCA1 and P53 genes, which predispose to breast and ovarian cancer. Those are tumor suppressor gene, and if there is already one mutation in somebody's cells, the second mutation is acquired quite quickly, and there is a big predisposition to the cancer. So, but this part, if there is a genetic background, it represents 1 to 10% of all breast cancer. So this is really small, tiny piece, the genetic predisposition. The majority of breast cancer is caused by somatic mutation and by acquired mutation. So I'll talk in details now about HER2 genes or ERBB2. It's the same gene, just two different names. And a couple of slides about FGFR1 gene. And in the end, it will be prostate. So breast carcinoma can be divided in two big different groups. It's in situ carcinoma and invasive. What is interested is an invasive component, because it's this one which will make the diagnosis and which we are checking in everyday routine. In situ carcinoma, there is no treatment by chemotherapy, since in situ is in the ducts, so theoretically it's never going out, so it should be there, and there only some lumpectomy is done. But sometimes there are some small micro-invasion, and this is the reason why in situ can become invasive. And sometimes you can have both components on the same slide, which is not very rare. And there are cases, those two components, they do not have the same genetic backgrounds. So it looks like two different genetic abnormalities. So there is a classification of a breast carcinoma of in situ. It can be intraductal or lobular in situ carcinoma, and invasive carcinoma can be infiltrating with otherwise not specified subtypes. Lobular carcinoma, medullary, colloid, papillary, tubular, adenoid, secretory, inflammatory, or carcinoma with metaplasia, and then Paget disease of the nipple. What is the frequency? So in situ is found approximately in 20% of cases, and invasive is majority. And I put here the histological subtypes. So the ductal is majority in 64%. So again, pathologists, when they examine the slide, he already knows for some kind of histology, some subtypes, he knows that he is dealing with a tumor of good prognosis if histology is tubular or mucinous, or he's dealing with a bad prognosis if it's micropapillary or lobular pleomorph. So what is very important, as I told on the slides, we have invasive and in situ components very often. So we need to check, to do all immunohistochemistry markers, estrogen receptor, progesterone receptors, and HER2 on this part. But it's interesting to see and to check what happens inside in situ carcinoma, because in some rare cases, what happens in our institute, when we do report, I report, of course, the results on this part. And in my file, I report the results to this file, but this is not a component which will decide the therapy. But in a couple of years later on, with a relapse, if these two populations were genetically different, I found the cases where the relapse was caused by these cells. So check, even in situ, if you have it on the slides, check what is going on there. It can be useful in a couple of years from now. So RBB2, it's a new or old marker. Actually, it's new marker as we saw for lung cancer, because it started to be examined in lung cancer, but it's old, relatively old marker, because this gene was started to be examined in 2003 with specific therapy called Herceptin, which is directed against the HER2 product. What is this gene? This gene is a human epidermal growth factor receptor 2 and is a member of a family protein which contain 4 members. The gene is localized on chromosome 17 on band 17q12. And it's a cell membrane surface bound receptor tyrosine kinase. So normally it's involved in signal transduction pathway by dimerization, which I'm going to explain on the next slides. The gene is amplified in 20 to 30 of all breast cancers. And amplification is a direct cause of its overexpression, because more we have a copy, more we will have a protein on the cell surface. And overexpression of this receptor is a prognosis marker, because if there is amplification or overexpression by immunohistochemistry 3+, the patient, she has a higher probability of recurrence and relapse. So what is this family of receptors? So here they are, all 4 of them. The first one, we saw it already in lung cancer, is HER2, or the second name, it's the same gene, EGFR gene. All these 3 has a ligand, but HER2 gene, or RBB2, doesn't have any. So what the protein does, will dimerize with the other family member, whatever, and then will send to signal to the cell nuclei for cell proliferation, cell survival, and mobility and metastasis. So how to prevent it? We have this special treatment called trastuzumab, or Herceptin is a commercial name, but it's the same thing. How does it work? Trastuzumab, or Herceptin, is a human antibody. So this antibody will go and will attach to the receptor. So it will prevent of dimerization. It will raise the destruction of the receptor. And this part here will activate, the immune system, especially NK, natural killer cells. So if this is attached, the immune system become active and will start to recognize specifically cancer cells which are amplified. So what we do, the first exam is, of course, histology, and the next step are receptors. Estrogen, progesterone receptors, and HER2. So we'll be interesting now only in HER2 part, because estrogen and progesterone receptors, they don't need to be checked by genetics later on. The HER2 doesn't need genetics either if we have negative cases and there is no treatment. It's 0 or 1+ case when the membrane is really weak staining, and we can see it at 10 to 20% really weak staining is the 1+. Without staining, it's a 0. And if it's really strong staining, it's a 3+, and there will be treatment. Where we do need genetics is the cases which are 2+. The staining is weak to moderate, between 10 to 30%, and some of these moderate staining can be related to amplification, and patients those show amplification of HER2 genes will respond to Herceptin therapy. Those who has no amplification will not respond. So very important is to check all cases which are 2+, it's this one, by FISH or by other in situ hybridization. It can be CISH or silver, but FISH is more sensitive than the other methods. I'll talk about it later. So what we are using in our institute, we are using ASCO-CAP guidelines. ASCO, it's American Society of Cancer Oncologists, and American and Canadian pathologists. They wrote already guidelines in 2007, and now 1 month ago they published a new guidelines. So what is different for immunohistochemistry? Before to have a positive score, we have to have at least 30% 2+, 30% of cells which were moderate to declare the positivity. Between 10 and 30% it was 2+, so FISH needed. Now it went down, so if you have more than 10% with complete and intense stain, you can declare tumor 3+. So it changes between before it was 10 to 30, now starting to 10%, you can declare it positive based on immunohistochemistry. What is new is this category 2. It's very difficult to now we have if it's less than 10% of complete and intense staining, we have to declare it as a 2+, so it needs to go to FISH. And when is the circumferential membrane staining is incomplete or very weak or moderate, then we need to do FISH again. If it's incomplete and really weak staining, it's 1+, and if there is no staining, it's 0, so it's negative case. What are the ASCO guidelines? What were ASCO guidelines for breast cancer concerning genetic? We did genetic testing, and we had a ratio. Ratio is the division number of copy number of the gene divided by its control. We obtain the ratio. Before, the ratio was superior of 2:2, it was considered as positive, inferior of 1:8 as negative, and the ratio between 2 was equivocal ratio. So we needed to check another block or another sample. What is new in ASCO-CAP guidelines is that there is the ratio of 1.8 to 2:2 as equivocal ratio. It completely disappeared. I'll show it on the next picture. The positive cases can be declared if the ratio is superior or equal to 2, and negative cases if ratio is inferior to 2. There are exceptions. The negative ratio, that we can have a ratio 1, but we can still declare the case positive if the copy number is greater than 6. It means this category is a category where you have the gene amplification, HER2, and its control, which is a centromere of chromosome 17. They are co-amplified. So there is a race of copy numbers of both of these. So if you have 10 HER2 and 10 17, the expression of protein will be erased, of course, but the ratio will be 1. So theoretically, it should be declared non-amplified. But since 10 copy expressed will erase the protein expression, and those cells will answer to targeted therapy, this must be considered as a positive case. The one case which I'm not agree and we are not applying those criterions is when the ratio is greater than 2 and average copy number is lower than 4 of HER2 gene. Why? Because this concerns monosomy. What is monosomy? Monosomy is a phenomenon where we have only one chromosome 17. So we have one centromere and one gene. It's a true monosomy. So this is a simple monosomy. But what can happen? The monosomy of the chromosome 17, which is in green, can go together with a gain. So we can have only one green, one control, and 2 HER2. Or we can have one control and 3 HER2 copy. And if you do ratio 2 divided by 1, it's 2. Or 3 divided by 1 is 3. So you would put all these cases in amplification, but those cases, when you look at the immunohistochemistry slides, the staining is really weak, moderate, or extremely weak, and these cases will not respond to the targeted therapy by Herceptin. So this is a big mistake to consider the gain, which is a very light number copy race, confuse it with an amplification. We have the monosomic cases where there is only one chromosome 17, which are really amplified, but it's more than 6 copies. So that category which says that average copy number is lower than 4 and ratio is more than great, it's classical monosomies or monosomies with a gain, which they don't do overexpress the gene. So we wouldn't apply this part of new rules in our institute. So the tumors are very heterogeneous, all of them. It applies especially for epithelial tumors. There is a little bit less heterogeneity in sarcoma and soft tissue tumors. What is heterogeneity according to ASCO CAP guidelines 2013? They recognize 3 types of heterogeneity as detected by immunohistochemistry. Either we have a big cluster of positive cells on negative background, or as I showed here, we have small subclones of positive cells on the negative background. And the worst case is if we have isolated amplified cells. What do we do with those, which we can see on this slide? Here, this is a complete moderate or quite intense staining, this one too, but the other cells, they are 2+. So we have like 3 cells or 4 which are really amplified or positive on the background which are 2+. So the major difficulty are cases 2+ with amplified isolated cells, and starting in which percentage of amplified cells by FISH we should consider tumor as heterogeneous or amplified. There are papers, they give the rate of heterogeneity 5 to 49%, which is a huge scale, but you really don't know what to do with these cases. So we do special exam, and I'll tell you about it in details, what to do with these difficult cases. So heterogeneity in breast cancer is not concerning only RBB2 genes. I'll talk about it because that's what we do, but heterogeneity can be detected in whole genome, and other genes can be different, can have different mutation status within the same tumor. What is interesting, there is the intratumoral and intertumoral heterogeneity, so you can have heterogeneity between different tumor areas, and then you can have heterogeneity between tumor and lymph nodes, or tumor and distant metastasis, or primary tumor and relapse. So the HER2 gene can change the status. There are a lot of papers. They are describing HER2 changement, but sometimes the heterogeneity existed in the beginning, but the clone was so small that it went undetected. So which are these genetic categories I'm talking about? It like more than 30 minutes, so let's go to see them. We saw the first one, and when I was not agree with ASCO and CAP guidelines, chromosome monosomy. Then we have chromosome disomy, polysomy, gain, and the category which is more interested because of the treatment is amplification. So I tell 1 or 2 words about each category. So this is a very heterogeneous case. When you see, this is a complicated case when you have an amplified cells on not amplified background. Or if you hear 1 amplified cells and not amplified background. So how this amplification can go and become true in cancer cells? There are several mechanisms which will explain the amplification. What is it, first of all? We need to know that amplification is a genetic process which results in selective multiplication of 1 or several genes or group of genes. And this unit of amplification is called amplicon. So what results is a very important trace of HER2 gene copy number comparing to the control, and the race of protein expression, of course. The amplification can be detected not only in breast cancer, but generally in 2 different forms. One form is HSR and one form is DM. What it is? HSR is homogeneously staining regions, and DM is double minute. Homogeneously staining regions are big clusters in a cells, and I'll show it to you on next picture how it looks like on karyotype. And double minutes are small structures, spheric structures, which are randomly distributed in a cell. So mechanism of the amplifications are many proposed mechanisms, but the most frequent are breakage, fusion, bridge, and translocation, deletion, and amplification. And there is an episome formation which can start the amplification process again. The breakage, fusion, bridge cycle is a cycle when one of the chromosome will lose the end. The end of chromosome is called telomere, and when telomere is lost, this end will become a cohesive end. So it's a little bit sticky. And after S phase, when the genetic material is duplicated and when the cell goes to G2, these 2 cohesive ends will connect because it's overlapping single-strand DNA. But the problem is not here. Problem is when the cell goes to mitosis. In mitosis, this chromosome, it's a 1 chromosome composed from 2 chromatids, but they are connected in the end, so it will be pulled and then it will be broken in some part on this common sequence, but then it will create again this cohesive end because there is no telomere. So in repeating this cycle, the cell will acquire many of these what I call amplicons, amplification units, and we will have a gene amplification, and homogeneously staining regions are formed by this mechanism. Then we have another 2 probable mechanisms. We can have episomal formation with, sometimes we have palindromic sequences. Those sequences are very similar, so DNA, double-strand DNA will connect with, will first open and will connect with other single-strand DNA which is close to it, and will form this kind of buckle or kind of episome. And this can be recognized by cell as a strange structure. So cell will repair it by repairing mechanism and will cut it here. So there will be this episome formation, and this structure can serve as a matrix for future amplification. Or there is another mechanism which is very often not only in solid tumors, but this was described in lymphomas. When the replication starts, we have a replication fork, and then within the replication fork, we have unscheduled replication which restart. And again, we have this round structure which are formed, and those structures are unit of amplification, so amplicones. And we have many of them in a cells, and by this mechanism, these double minutes are generated. So what are these double minutes and all this homogeneously staining region? Double minutes are round structures which are usually organized by two. They are 2 and 2 and 2 and 2. And their distribution is random in dividing cells because they do not have centromeric region. So it can be 90%, 10%, 50-50, 40-60, whatever. So the cell, to prevent the loss of the double minutes, will organize these double minutes in all these huge structures which become homogeneously staining region, which will be integrated non-specifically in somewhere in the genome, but which will be translated to the protein and which will raise dramatically the level of proteins in the cells. So homogeneously staining region, why this name, bizarre name? Homogeneously staining because when we do chromosome bending, these units of amplified gene, which are 10, 20, or 30 times one of each other, there is no bending pattern. It's either all black or either all white. There are no bends, so that's why we call them homogeneously staining region, because by doing bending on chromosomes, there are no bending patterns because it's the same sequence. So it's logical that there are no bendings. And when you do fish, you can see this huge structure on chromosome, or when you do breast cancer, you can see these big clusters of red dots all together. So those are homogeneously staining region. So again, we can have amplification as double minutes, which are these round structures randomly distributed in the cells, or homogeneously staining region, which are big clusters in the cells, which are integrated in the genome and which are not lost or distributed randomly in the cancer cells. So as we saw, we have monosomy and amplification. The disomy is we have just two chromosomes, like every human cell has two chromosomes, one paternal and one maternal chromosome. So this is the case in a lot of breast cancers, especially in 0-1 plus, you have only two copies of chromosomes. Monosomy, we saw it 5 minutes ago. And then we have a category called polysomy. What is it? Polysomy is a gain of some chromosomes, I put it twice, I'm sorry, as compared to the total number of chromosomes detected by karyotype. So when we have a karyotype and we have trisomy 21, we have Down syndrome. So it's a whole chromosome, which is cernumerary chromosome. It's one copy of one chromosome. If we have two different chromosomes, it's a double, trisomy, triple, but we're dealing with a whole chromosome. As is defined by cytogenetic rules. But what happened in cancer, this polysomy is never attending the whole chromosome 17 where the gene is, but it's only attending a part of the chromosome, and we call it segmental polysomy. So in breast cancer, polysomy of chromosome 17 is declared if we have 3 or more copies of the gene and the control region. So what does it mean? We have like 1, 2, 3 green, 3 red, or 4 green and 4 red. So this will be trisomy, tetrasomy of chromosome, etc., etc. So, but what happens in breast cancer? The definition of polysomy, that it's equal number of centromeres or control and HER2, it's only theoretically. Because in real life, we never have this situation. As I try to design some chromosomes, we have this, what we call segmental polysomy. So one chromosome is just one part, the other is bigger part, the other chromosome can be the whole part. How we found out this without karyotypes, because cells are very difficult to put in a culture and obtain the karyotype. It was done by CGH arrays, and as you can see here on this chromosome, there is a centromeric region amplified together with HER2 genes. On this chromosome, there is only HER2 genes amplified. On this chromosome, there is a HER2 gene, centromeric region, and other gene between these two, which is amplified. I gave here 2 example of CGH array we do in Agilent in our institution, and you can see that this huge region which is amplified contained RBB2 gene, which is right here. So, and when we look the profile of the whole chromosome, this is a gain, this is a loss, this is a gain, this is a loss. So this reminds very much this new phenomenon what I talked about this morning, chromotripsis, when in one genetic event we have many gain and losses along the chromosome. So why we cannot declare polysomy with only 2 FISH probes? Because FISH probe, we have 1 probe here and 1 probe here, so we detect only 2 loci. As you can see, it's very rearranged, so-called polysomy chromosome 17. Without any precision, the precising methods or supplementary method is very difficult, so don't call polysomy easily if you deal with the breast cancer. So in the last category, we have a gain. What is the gain? Gain is HER2 gene copy number, which is slightly higher than the control copy number, but ratio will never be superior to 2. It can happen by duplication or by unbalanced translocation. We have just 2 normal chromosomes, and 1 chromosome can be duplicated on the chromosome. One HER2 gene is duplicated on one of 2 chromosomes 17. So we have 2 controls and 3 dots. So like here, you have 2 controls and 1, 2, and 3 dots. So this can be a possibility. Or we can have, which we call unbalanced translocation between 2 different chromosomes. There is a HER2 gene which will be translocated to another chromosome, and one cell will have only 1 chromosome 17 and 1 HER2 gene which will be monosomic, and the other will have a partial polysomy or gain of HER2 gene. It will have 3 copies, and this cell will have more selective advantage than this one. Although, as I told, monosomy exists, and these cells can function because they acquired another genetic abnormalities. I'll give you just 2 examples to see how not easy it is in breast cancer. So we have the first case. We have a surgical piece. It's pièce opératoire and ganglion lymph node, which were very heterogeneous. And when we analyze it, I didn't translate it because we need to see just numbers, so don't worry about translations. For the microbiopsy, we have the ratio 170, which is case not amplified. Then we have a copy number 555, which is still non-amplified, but 1/3 of tumor cells were considered as positive, and we have 14 different categories, genetic categories. We have normal, gain, amplification, polysomy in different variations. So even if we could declare this case as non-amplified, this was bothering us a little bit too much, that 1/3 of tumor can be considered as amplified and can be maybe treated by specific therapy. So we went from microbiopsy to surgical piece to find out that the ratio went down to 150. An average number, HER2, went from 5 to 4. We had, instead of 14 categories, only 11. And number of positive clones went from 30 to 19. And for this patient, we have involved lymph node. So we check lymph node to complete our exam, and definitely the ratio went even more down. The average copy number had to again down, and we had only 9 genetic categories, so we are very comfortable to declare this tumor non-amplified. The second case was a little bit similar. You have this amplified 6, so we could declare it as an amplified, and we detect the HER2 aberrations, HER2 positive cells represent half of tumors, so it's quite a lot. But from microbiopsy, we still could go to surgical pieces, and ratio went from 169 to 199. The mean number, copy mean, went from 6 to 8, so, and the number of positive cells went from 50 to 85, which was really easy to declare the tumor as amplified tumors. So you have all these different genetic categories, and if you divide them in details, it will give you really nice background what's going in a tumor. And if you have those and you keep them in your records, when there will be relapse in a couple of years, you can say, oh, I already told you there were some minority clones, and you already saw them 5 years before. So if you do this analysis, I know it's very long. It takes like 1 hour per slide, but it's very useful to find out what's going in tumor and how will be the possible evolution of the tumor cells. This is a really good paper which just appeared 2 months ago, and which gives really in detail how to analyze polysomy, how to analyze genetic heterogeneity. It's a team of pathologists from 1, 2, 3, 4, 5, 6, 7, 8, 9 different labs, United States, Canada, and Europe. And this paper is extremely clear and extremely well done. So if you work on breast cancer or you do some research, and you want to apply this methodology, you may read this paper. So what are new targeted therapy for RBB2 amplification? There is a new molecule, TDM1, which is almost the same principle as Herceptin or trastuzumab, but because it's a monoclonal humanized antibody which will recognize the receptor. But what is new, there is a cytotoxic agent attached to that antibody. And what is the mechanism of action of this molecule? The molecule will enter to the cells, and once it is in the cells, the chemotherapy which is attached on antibody will be released and will inactivate the microtubule polymerization, so cells cannot do cell division anymore because microtubules will be inactivated. So that's why there is very, very important to do these genetic categories, because we are having very, very, very specific treatment, which treatment is depending on our results. So if we want to do a targeted therapy and if we want to do it well, it's really better to do all these genetic categories. What is really rare even, I mentioned it this morning, is translocation in breast cancer. It's really just 3 seconds on this slide. There was a nice paper which described the translocation in 547 invasive breast carcinoma. 5 of them showed ETV gene rearrangement. So it's very frequent in juvenile carcinoma, but majority of time it's gene amplification of receptor deregulation. We can detect the RBB2 gene or other genes not only by fish, by also array CGH. So we used in our institute adjuvant CGH array, and as you can see on this profile, there are many rearrangements. This is lost, gain, so this tumor is really rearranged, but we are interested in chromosome 17, and the gene RBB2 is right here, so there is an amplification. For some trials, we use CGH arrays as a pre-screening to find which gene is amplified, but even if we find the amplification, this is not a method where the treatment can be given. It still must be confirmed by fish. So on the same case, we did the fish analysis, and we really saw the race of number of HER2 genes, and ratio was superior of 5. So we could treat this patient with Herceptin or trastuzumab. What are new pathologies in which these old genes we know for 10 years now can be activated? So the classic example is stomach cancer, because there is more and more amplification detected in stomach cancer, and I gave you the papers here. There is bladder cancers, they can have an amplification, and as I told earlier, non-small cell lung cancers can be either mutated or amplified, very rarely, but some, but more frequent there are mutations, and I gave you some of the examples here. So the gene we saw in lung cancer, but which is activated more frequently in metastatic breast cancers, is fibroblast growth factor receptor number 1, because there are 4 genes. This gene is located on chromosome 8, and again it's a member of family of 4 genes, and this gene is amplified in 8 to 12% of breast cancers. It's involved in tumor growth, survival, and resistance to the chemotherapy. The genetic categories by fish are the same as those we saw for HER2. So if you have one model, you can apply it to other pathology or other gene. So it's simple if the concept is the same. So the gene can be amplified if the copy number is really high. The difference, this probe, the gene is green and the control is red. For RBB2 it was the opposite, but you just have to know who is who, and it's really easy to read the slides. The amplification can be low or can be quite high. Low amplification we can see here. And the very high amplification, this clusters, homogeneously staining region, we can see here. The ratio was superior to 6. The gene FGFR, as the other gene, HER2 or whatever gene, can be gained. So it means there is a slight raise of gene comparing to the control. So we have 3 red controls and 4 greens. 3 controls and 4 greens. 3 controls and 5 greens. So this is a gain of the gene. It's not a polysomy because the number is not equal, and it's not amplification because the ratio is not superior to 2. We can have a polysomy which is low, which can be high. So low if we have 3 copies, like here. If high polysomy, if we have 4 to 5 copies, like on this slide. And polysomy very high. It's more than 6 copies. It can go up to 10 to 12 sometimes gene copies of chromosome 8 and the gene FGFR1. And those very high polysomies, they behave exactly the same way like amplification. They express the receptor on the surface of cells the same manner as amplified cells. This gene, as the previous one, as RBB2, can be detected by array CGH. Again, so we do our array CGH, and what we can see on chromosome 8, there is a huge peak here, so which means FGFR amplification. And again, we have to check by fish. So first we check it on paraffin sections, and then there was a invaded lymph node. Our cytologist sent me a cytological slide, and we could confirm that there is only 2 control probes and many, like 10 to 20 copies of FGFR gene. The last gene which we detect is ERG gene in prostate cancer. So the gene is located on chromosome 21, and it's found rearranged in 45 to 60% of prostate cancer, which is really high, because as we saw, the RBB2 gene is amplified in 20% of breast cancer. ALK gene is rearranged in 3% of lung cancers, but this is very specific because it can go up to 60% depending on the method used and on the paper and number of cases. It can go up to 60%, so it's very specific. The gene, the regular translocation with ERG gene with his partner TMPRSS2, which are both of chromosome 21, and again there is inversion. It's inverted. This part goes down and this part go up, so there is inversion on the same chromosome. There is not only these 2 genes, but those 2 genes are part of ETS gene families, and there is a lot of family members. So you can have, you cannot read it because it's too small, but there are like 10 different genes which can cause the prostate cancer. And here there was a nice paper published in 2011 in Journal of Clinical Oncology, how we go from prostate epithelium to metastatic prostate cancer, and there are different genes and different genetic abnormalities which are found in different stages, from normal epithelium to neoplasia, invasive prostate cancer to metastatic cancer. So this is a really nice publication. So what is interesting on this gene is the total opposite to what we saw this morning, one gene, many pathologies. This is the opposite concept, many gene, one pathology. So why? Because those genes are the same family members. So we can have prostate cancer caused by 10 different genes, which is again a very nice concept which we didn't know about it like 10 years ago. We didn't suspect that one pathology can be caused by 10 different genes. How it looks like in the cells. So we have here we have 2 different population. This is a normal allele, normal ERG gene, and this is a split gene, so there was a translocation. There was another type of cell, probably triploid, because there were 3 copies of the gene, so there are 2 copies which are normal, and 3rd copy of the gene is split, so there is a translocation, but it was in the same tumor. And we can detect it, this was on FNA, and this is on paraffin sections. So we can detect it. Here is a green and separate red. This cell has no rearrangement because there are only 2 yellow signals. This has 2 yellow signals, one red, one green. So usually it's a mixture of different clones similar to the breast cancer. And there is what I wanted to mention in the end. What's really interesting is this new method of circulating tumor cells. There are 2 different methods of detecting them. Veridex, it detects those cells by antibodies, by CDs, by cytokeratins. Or there is a method we use in our institute. It's filtration of the blood through the filter, nitrocellulose filter. So we filter the whole blood. As you can see, the pore on filters these holes, which lets the blood cells go through because there is under pressure on the filter. So all blood cells go through, and we can keep the tumor cells on the filter. The problem is when the tumor cells has the same size as the pores, they go through, And what is very difficult is do immunostaining and fish on this membrane, in which the filter must be attached to glass slides and then immunostained, or we make a fish. The problem with this method that we have a little amount of tumor cells. So sometimes we have 50, but sometimes we have 5 cells, and it's not right to give the results on 5 cells. And very often the circulating cells doesn't correspond to the reality, because tumor can be different from these circulating cells, because the circulating tumor cells can go to the other niche, divided by themselves, and go to the blood circulation again, and they went from other location than the primary tumor. So for the moment, this is just screening method, which is used for some trials, but it's not used in routine practice. I just wanted to know that it exists, and there is more and more labs. They are doing circulating tumor cells as a non-invasive method, because it's really easy to take a blood instead of doing biopsies. So I thank you for your attention.
Bom, nesse momento a gente abre para as perguntas. Alguém gostaria de fazer alguma pergunta?
You have described several gene mutations resulting to ALK, HER2, and ERG mutated phenotypes. We have also seen mutated phenotypes on HAS and p53 genes, those being traditional targets for anti-cancer therapy. But in recent years, literature has described the importance of exokinase 2 in breast cancer in what regards to the so-called Warburg effect, in which cancer cells neglect Krebs cycle for the sugar metabolism and rather rely on glycolysis for ATP generation, mainly due to the overexpression of exokinase 2. And my question is, if there are any efforts being made onto cytogenetics to possibly describe exokinase genes as a biomarker for malignant tumors.
We don't do exokinase 2 in our institution, but they are, I don't know which lab doing it in France, but they do effort to do it. But I think it will be more molecular biology description or more sequencing than cytogenetic, but they are cytogenetic aberrations, but I don't know if they are related exactly to the gene or no, because sometimes you can have a cytogenetic aberration which can be detected by fish, and sometimes the small mutation must be sequenced because, or there is small deletion that cannot be done by fish. So I cannot answer your question precisely because we don't do it, but there are labs they doing this work, but we don't do it, I'm sorry.
That's him. Yeah. I was curious about this last slide you presented about isolated tumor cells, because is there a way to find out, maybe by genetics analysis, which one can, because the tumor cells can circulate and maybe they cannot inflame. So is there a way maybe to figure out which ones are just circulating but they're not contaminated, and those we will maybe
It's a big problem because there is a so-called epithelial mesenchymal transition between those cells. They make transition from epithelial to mesenchymal phenotype, and sometimes it's only switching by the gene function. At the genetic levels, they are the same. So it's very difficult to say which one will give the future metastasis and which one will not give. And the releasing of circulating tumor cells is very random. And as I told, you can have a cell released from the primary tumor, but they can go to circulation, sit somewhere else, do some changes, which can be genetics on the genome level, mutations, or just epigenetics, and they switch the phenotype, and then they go again to the circulation. So it's really difficult. If you want to do it very precisely, you would have to microdissect those cells from the filter one by one and do the genome one by one. It's not feasible for the moment. So what will be more practical will be doing what is the majority clone and what changes are in majority clone, and if is the epithelial mesenchymal transition is important, if it switches in both way or if it switches only in one way. And in this way we could try to detect first of all phenotypic changes, because it's really easy to capture those by cytokeratins, and then we go to genetic changes. But this is really only first steps. It will take at least 5 years to get to the patients. It's a research method, but I wanted to mention it because it may go to the clinics, but not next month.
About the heterogeneity of the cancer cells, you showed many cases that there are some percentage of cells with a amplified HER2 gene and other cells with no HER2 gene amplification. How many cells are necessary? The percentage of cells are necessary for you to say that there is a HER2 amplification, that the Herceptin treatment will be good for the patient? There is an answer for that?
There is no consensus on this level. Minority clone is considered from 5 to 49%. If it's 50, it's half-half. But it's a huge scale, 5 to 49. What we do, and it's in France, our national consensus, we do not mention anymore the minority clones which are less than 10%. So if it's less than 10%, we do not even mention it in our results, for the simple reason those minority clones were created by secondary or tertiary genetic changes, and those cells are so rare that this is not the reason why tumor is there. 5% of cells, it's such a small part of tumor that it doesn't make sense to treat because the tumor won't respond. So less than 10% do not mention it. Those are secondary genetic changes, and those cells are so rare that they won't change any prognosis. Then we mention them if it's 10 to 40%. And we just mentioned there is a minority clone which is 10 to 40%, but we don't know its influence to the prognosis. And if it's more than 40%, we mention it that tumor is heterogeneous, and heterogeneous tumor are treated with Herceptin. So above 40%, it's almost half of tumor. So when you have more than 40% of cells, you declare it not amplified because you have 60% of cells which are not amplified. And the ratio can be lower than 2, but if you mention heterogeneous tumor oncologists, they will do all the parameters. They will see if there is a metastatic disease. They will check the progesterone estrogen receptors. They do the histology grade. And if the tumor is really aggressive and the HER2 is amplified, they like to use the Herceptin as reinforcement to the classical chemotherapy. So above 40% and no less than 10% did not even mention it.
Mais alguma pergunta? No. Thank you very much.
So it's another question, completely different. You showed us some alterations in some genes, deletions, amplifications, and you wrote about the NF1 gene deletions in many tumors. I would like to know your experience with that, about the NF1 deletions in those tumors, if you could tell more about that?
We didn't do any checking of NF1 gene. What we did check was TP53. It's another tumor suppressor gene which is very frequently lost in metastatic disease. When the patient comes and is already metastatic, in many cases, it's almost like 50% of them, we did the CGH erase to find the targeted therapy, and we found out that there is a TP53 which was lost. There is a deletion. But we didn't see the copy number change for NF1 gene, and we didn't do mutation tests, so I cannot answer your questions. I can only tell you that copy number change was not detected, but we didn't do mutation analysis of NF1 in those cases which are metastatic. Yeah, it did change quite dramatically, because before I had a lot of cases which were not amplified and which were checked by FISH basically for nothing. But now the procedure is quite standard. There is positive and negative control. There is a positive control on each slide and 3 controls on every run, the machine when runs immunohistochemistry. So, and the lecture was done by our main breast pathologist for all pathologies for like 6 months in a row, and now everybody is reading the same. So now the cases which were checked by FISH went really down. So now the reading is so synchronized and so well done that I have less cases to check. The amplification level of 2+ remains approximately the same during the years, which means 30% of 2+ is amplified in our institute, but it can vary from one institute to the other. What will be raised, the number of cases, I will have like 20% of 1+ cases to check by FISH more, thanks to new guidelines, which brought down the percentage of positive cells. So this will raise approximately 20% of 1+, which will go to 2+ cases, which won't be amplified, because 1+ by definition are not amplified, except if you read some Australian studies with on 35,000 cases, they found 1% of amplified case, but we won't go there. But now this new criterion will raise, in spite of the fact that the pathology reading is really objective now and really well set up, we will have more cases checked by FISH because of changing of criteria. Before it was like 5 years ago, it was like 1/3 of labs, they've been doing CISH, just regular probes on normal light, normal microscope. But all these labs, now there is only one or two labs in Paris and 1 or 2 labs in outside, so which is like maybe 5% of labs, they keep CISH, because CISH is less sensitive than FISH. So people which were doing CISH are switching for FISH and buying fluorescent microscope, because by CISH, when you apply your antibodies to reveal the signal by peroxidase, 2 spots close together become 1 spot by FISH, but by CISH, but by FISH I can see still 2 spots. So the counting is more precise and more correct by FISH. fish is really one spot, and if it's sitting next to each other, it will be still two spots. It won't become one spot like when you do antibody application on your slide.
What's your advice when you want to see a duplicated gene, BRAF, for instance, in phagocytoma? Today, this is a diagnostic criteria. And if you have a doubt, you can use the duplication of the BRAF gene, and this will corroborate your diagnosis. But that has quite a species, so it's hard to get. So, do you have any ideas of the ways you can do this with fish? Or you think it's better to try to by CGH? Or?
It's easy to see it by CGH because the ratio will be raised up. The problem by fish, the duplication sometimes can be seen if the duplicated region is big, and we will have two spots together. But if the region duplicated is too small or they are close together, you will see only one small or one bigger spot, but it will be still one spot. The resolution of optical microscope is not the same like DNA level. On DNA level, you will see it more precisely, and you will see the borders of this duplication. On microscopic level, sometimes you can see it and sometimes no. So I would prefer CGH instead of doing fish probes. In these cases, it's more sensitive.
Okay, thank you. Passamos agora a palavra à professora Karen Gonçalves, coordenadora do programa de pós-graduação em patologia, para o encerramento.
Então, primeiramente, eu gostaria de agradecer ao Dr. Valent. Thank you very much again for this wonderful presentation. I'm sure all of us learned a lot today with your lectures. Thank you. E eu gostaria de agradecer não só ao Dr. Valent, mas todos os professores que vieram aqui nesse encontro, nesses 3 dias de encontro. Quero agradecer também ao comitê executivo, né, alunos daqui da pós-graduação em patologia, de doutorado, pós-doutorandos e do programa do PBBI. Agradeço a todos os programas de pós-graduação que participaram junto com o programa de pós-graduação em patologia. Foram 5 programas que coordenaram esse evento, incluindo o programa coordenado pela professora Helena Carla Castro, que é o PPBI. Obrigada, professora Helena. Trabalhamos duro para esse encontro. Eu acho que espero que tenha sido proveitoso para todos e espero que tenha sido o primeiro de muitos outros encontros. Agradeço a todos vocês pela participação e agradeço também a Pró-Reitoria de Pós-Graduação e Pesquisa e Inovação daqui da nossa universidade, que foi através de um edital da PROP, um edital de internacionalização, que foi possível fazer este evento. Então, agradeço imensamente. Muito obrigada a vocês e convido a todos para um singelo cafezinho aqui fora. Muito obrigada. Boa tarde.